We're bringing you tonight a webinar where you've got the opportunity to ask any question you want of our consultant, Luciano Nardo, and our fertility nurse, Balchan. So without further ado, I see people are putting questions into the Q&A and the chat box. I'll move from one to the other, whatever you feel most comfortable with. But before I start there, I've had quite an amount, as I mentioned earlier, of patients who've already written in with their questions. So I'll start off with them and then we can go from there. So Luciano, the first questions I'm going to ask is, a patient has said they've recently been told they have a high chance they have Hashimoto's disease. Their antibodies were in the thousands. They've been put on a drug called levothyroxine, but that actually hasn't dealt with the autoimmune part of the Hashimoto's, and also been struggling to find any UK-based support on this and fertility. Their first IBA transfer failed, and they're about to start medication for their frozen transfer. Do you have any advice of what they could do to maximise their chances of this transfer working?
Yes, absolutely. There are some published studies suggesting that Hashimoto thyroiditis, which is an immune form of thyroid disease, has or may have a negative impact on female fertility. Can also be associated with reduced ovarian reserve, but in most cases, because of the immune component of the Hashimoto syndrome, could impact on implantation potential and could cause early pregnancy loss. My advice will be to undertake treatment using levothyroxine, which is correct, and for TSH levels at less than 2.5, but also with low dose steroids in the form of prednisolone. The recommended dose of what I use for my patient will be 15 milligram daily, as well as low dose aspirin, 75 milligram at night. And it's important that taken at night. That seems to be more effective aspirin taken in the evening than taken in the morning.
Okay, thank you. Next question, I've got a patient here that's had 9 early miscarriages over the last 4 years. They've had all of the tests available in the NHS. They don't smoke, drink, they lead a healthy lifestyle, and they've tried reflexology and acupuncture and sought out a private nutritionist. They've also tried progesterone and suppositories. They've got their first consultation with an IVF clinic on the 25th of July. They've ordered all the basic usual blood tests, HIV, TSH, rubella, etc. They've had karyotype and bloods done, which were normal, thrombophilia screening, all come back normal. What questions would you advise that patient to ask at the clinic at their appointment on the 25th? And would you recommend PGD testing, stroke, or ICSI?
I think miscarriages, pregnancy losses, implantation failure are a dilemma for clinicians, and there is no solution, there is no answer that we can give to every patient. We know that there are many causes of miscarriage as well as implantation failure, and it is important that all of them can be or should be excluded before a diagnosis of unexplained recurrent miscarriage is made. I would say that, I don't know whether this patient has had a diagnostic hysteroscopy, but I would say that the diagnostic hysteroscopy is an important test to ensure that the inside of the uterus is normal, because abnormalities within the uterine cavity, such as adhesions, congenital abnormalities such as uterine septum, or some abnormalities in the normal environment of the endometrium, so a form of endometritis, which is an inflammation of the inside of the uterus, could all cause miscarriage and implantation failure. So my recommendation would be, first of all, have a diagnostic hysteroscopy and possibly an endometrial biopsy. And that is useful to rule out the instance of endometritis, whereas the hysteroscopy itself to exclude any abnormalities. If the diagnostic hysteroscopy is normal, then I would encourage to have pre-implantation genetic testing of the embryos at the stage of blastocyst. PGTA doesn't increase the chance of success in IVF, hence why it's not regarded as conventional treatment. So I'm not encouraging my patients to have pre-implantation genetic testing to increase the chances of pregnancy, because it doesn't change the embryos. But what pre-implantation genetic testing does, reduces the risk of miscarriage. And there is plenty of evidence to suggest that by selecting euploid or genetically competent embryos, we can reduce the risk of miscarriage. But we need to be sure that there are no other confounding factors, because if there are abnormalities inside the uterus, for instance, then even transferring a completely euploid, completely normal embryo will not make a difference to the chances of implantation, or indeed reducing the risk of miscarriage.
And what do you think about ICSI? Is that worth, do you know, for recurrent miscarriage? Does that make any difference whether it's a ICSI transfer or an ICSI cycle? Yeah.
ICSI.
Yeah.
It does. There's no evidence that ICSI compared to conventional IVF increases the risk of miscarriage. ICSI is only done in cases of male factor infertility.
Yeah. Okay, thank you. Moving on. Why would endometrium cysts affect fertility?
You're saying endometrial thickness?
Cyst.
Cyst.
A cyst in the endometrium.
Yeah. So the endometrial cysts are normally pockets of fluid inside the layer between the endometrium and the myometrium, which could be associated with either inflammation or adenomyosis. So that is what would be affecting the fertility. It's not the cyst itself, but the cyst is the appearance of an underlying endometrial problem. So I encourage patients that are found to have endometrial cysts seen on ultrasound scan to be investigated, to make sure there is no appearance of adenomyosis and that there is no endometritis.
Okay. And if there is, how effective is the laparoscopy in removing those cysts?
Women don't need a laparoscopy to remove cysts within the endometrium. They may need a hysteroscopy, which is a procedure done putting a telescope inside the uterus through the cervical canal and the vagina, obviously.
Okay. And that procedure, is there any risk to damaging the fallopian tubes or the ovaries?
There is no risk to damage the ovaries. The only risk to damage the fallopian tubes is if the tubes are already damaged, because blocked tubes can cause accumulation of the fluid that we put inside the uterus to look at the cavity, getting trapped inside the fallopian tubes. But normally before a hysteroscopy is done, the gynecologist or the fertility physician will be performing an ultrasound scan just to make sure that there is no fluid collection inside the tubes, which could hinder appearance of hydrosalpinx. In that case, hysteroscopy will not be indicated.
Okay, thank you. I'll probably come back to that because I see the supplementary questions getting asked in the Q&A in the chat. Somebody else has asked, what's your feelings on exercise and fertility? Is it a good idea to exercise when you're going through the IVF process, after embryo transfer? They've heard that exercise can induce uterine cramping. Others have said it helps increase the blood flow, so they're really mixed up about whether they should exercise during the whole process or not.
I think, Sharon, perhaps Anna will be better suited to answer this question, as she is the one that advises the patients coming to NOW-fertility. And also she can share with the audience the links on some of our useful fact sheets on the website. So I'll leave Anna to answer that question.
Hi, so yeah, I think the advice from the nurses about the exercise is not to stop completely, but maybe just do it light exercise during the treatment, so light yoga, light Pilates, but nothing too hard. Obviously, towards the end of the treatment, close to the time when obviously the patient is ready for the egg collection, the advice will be probably stop, because they may not feel comfortable to continue with the exercising once the follicles are growing. Also depends how many follicles they have in each ovaries. This may cause the pain, and obviously because of the tummy is slightly swollen close to the end, they may stop anyway. And the same will be after the transfer. Of course, we are not advising to stop completely the exercise. Again, light exercise are fine. The advice will be not to lift anything, especially after the transfer, but obviously walking and again, light yoga, light Pilates are fine. And there's no increased risk of the cramping or anything if they are obviously doing as we are instructing them. So as obviously Mr. Nardo said, we have the information on our website. We have the information about the transfer and obviously what to do after the transfer regarding of the special exercise and the diet, and obviously everything is available.
So leading on from that question, and I'll stay with you, Anna, acupuncture, I know it's, you know, one of the things that some people swear by and it helps them. I'm not sure about where the science sits behind it from a charity's point of view. We think, you know, if acupuncture is helping your emotional, mental health, well-being, then go for it. But is there any evidence out there that it actually can aid with fertility success rates?
I mean, there is no strong evidence that acupuncture can help, so obviously we cannot advise, but I know lots of patients is asking about this. So I think there is worth to try. Obviously, there is no harm of having the acupuncture before the treatment or during the treatment or before the transfer, but we are always saying that obviously we cannot support this with the evidence, like clinical evidence.
Yeah. And similarly, alcohol and fertility. So the advice is not to drink alcohol during the whole process, but a patient here said it can be really stressful. Can they have a glass of wine, you know, prior to actual transfer during that whole period of, you know, the nasal spray and the injections, or is it completely off the table?
When I'm obviously doing my consultation with the patients, this is a very common question, especially if there is any family event around the time when they have a treatment and they don't want to say they are having a treatment, but at the same time they cannot drink alcohol. So my advice will be 1 or 2 glasses of wine during the treatment, especially once they obviously have these events between, is not a problem. Of course, not too much alcohol during the treatment because they are taking the medications. So it will be the same as with anything else. Once you are taking the medications, you shouldn't really have too much alcohol. But I think, as you said, the treatment can be stressful and sometimes they have one after another. So yeah, they can have a glass of wine. It's definitely fine. I'm sure Mr. Nardo will agree.
Yeah, I agree. I agree fully. I agree with everything you've said, Anna. And with regard to acupuncture, I think there is a difference between is acupuncture beneficial or is acupuncture harmful. So acupuncture is not harmful, but there is no strong, consistent, robust evidence to suggest that actually acupuncture improves significantly the chances of success. For the same reason why there's no significant evidence for other complementary therapies, we cannot advise patients to do. But equally, if you feel that that could benefit you, the same as counseling could benefit you, the same as fertility coaching could benefit you, then yes, indeed, you can explore it. But just let me share some very useful and, in my opinion, robust evidence that comes from a publication in the Journal of the American Medical Association, which showed that a group of patients that had acupuncture had a live birth rate of 18% or 18.3% compared to a group of patients who did not have acupuncture that have a live birth rate of 17.8%. So you can see that the difference between the two groups is not significantly different. That's what I quote to my patients. So in my opinion, the journal, the article published in the JMA is probably one of the best articles. It's evidence, it shows clearly there's no disadvantage, there's no harm, but there's no benefit.
Thank you. That's really interesting that there is scientific evidence out there, because it is something that lots of patients, I see it in peer support groups, who tell other patients that's what made their cycle successful, but the science says otherwise. Okay, another patient's asked here, they've been looking at clinics in the EU countries, as many of them are cheaper than UK clinics, and what they want to know, are EU clinics regulated the same way as the UK clinics?
Okay, I will just take that question. It is difficult for me to talk about and generalize all the clinics in the European Union or clinics in other regions. I think, generally speaking, the level of care, the quality of service is excellent in all the IVF centers I know across Europe and in some other regions as well. The difference between the UK and some European Union is the evidence that you as patients have of the quality of service and success rate within the clinics, because not all the European Union have the authority like the HFEA, which collects data from clinics and requests data to be validated. So the difference is not whether the clinic is good, is reputable, it's got good quality management system, it's got good doctors, good embryologists, good nurses. It's more, can I trust the results of a clinic where there is no regulatory body? And I cannot give you that answer. The treatments are cheaper in some European countries. We have some of our clinics within the European Union, in Poland, in Greece, in Spain. We have also a clinic in Tunisia, in Egypt, and all clinics, part of NOW-fertility, they have to fulfill the same standards. So the same standards of success rate, the same standards of quality management, and so on and so forth. And we know the differences are not because of the standards of care. The reason why the treatment in the UK is 3 or 4 times higher than in Tunisia is not because the standard of care is better in the UK, only because the quality of life is more expensive. And that is reflected in the cost.
Okay, thank you. Another question, you actually mentioned the HFEA there. What's your feelings on endometrial scratch? This is on the red list as an add-on with the HFEA, but we'd be interested to see what you think of it as a clinician.
We don't recommend the endometrial scratch. The evidence is very, 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 very little, and there is no study that shows with confidence that performing the endometrial scratch enhances the chance of successful implantation. And I agree with the positioning of endometrial scratching within the red flag list by the HFEA, because sometimes patients have to be guided by the regulatory body and not just only by the clinician about what is the best approach. And I don't recommend an endometrial scratch. Obviously, if a patient wants to have an endometrial scratch, I wouldn't be doing it because I don't believe in it. But the patient is free to seek a clinic where that can be done.
Thank you. Okay, I've got another patient here who's 42. They desperately want to try another cycle using their own eggs. However, the clinic they're currently with is pushing them to use donor eggs. From their last egg collection, they retrieved 3 eggs and made 1 embryo. It was graded a 4BB. However, it was unsuccessful and didn't implant. Is there anything you would suggest to improve their egg count, to try using their own eggs again, or would you counsel them against going through another egg collection?
I think this comes down to expectations. And provided that the patient has a realistic expectation, she knows that the stimulation may be cancelled, may not be eggs collected, the eggs may not be mature, the collected eggs may fail to fertilize, the fertilized eggs may fail to reach the stage of blastocyst. It is possible. Fertility is a choice. I think it has to be an informed choice. If a patient of that age comes to my clinic, I would certainly recommend donor eggs, because I know that the chances of success are 12, 15 times higher with donor eggs as compared to own eggs. Equally, I would not be saying, no, you cannot have an attempt with your own eggs, provided that the patient knows the potential outcomes, which are negative outcomes, which are far more likely than a positive outcome. Within our network of clinics, we have some clinics that have an age limit of 32, 33, 35, and some don't have an age limit. As long as the information shared with the patient is clear, consent forms are signed, and expectations are realistic.
Okay, thank you. I think there's more on that later. I have another patient, and I don't fully understand this because I'm not a clinician, but I hope it makes sense to you. And the question is, how much impact does low morphology have on the chances of conceiving naturally? They were told by their consultant no evidence to suggest how much of an impact, if any, on their chances of conceiving, but they've been told very recently, after 3 failed ICSI cycles, something different by a natural fertility expert. So they're getting conflicting advice between a clinician and a natural fertility expert. So the clinician's saying it's not making any difference to the chances of them conceiving. They have had 3 failed ICSI cycles, but they've obviously sought advice from a natural fertility expert.
Okay. So I assume the morphology we're referring to sperm morphology.
Yeah.
There is evidence that lower quality sperm is less likely to produce good quality embryos. Okay, that is a fact. And the lower quality sperm is the same if that lower quality sperm is used in an IVF-based technique, or the lower quality sperm is ejaculated in the vagina. That doesn't change. The only difference is in an IVF-based technique, perhaps ICSI, the sperm can be selected. Now, if the sperm is morphologically abnormal, then it's more likely than not to create an abnormal embryo. And that is increased in women of advanced chronological age. So if we have more than one factor, say you have low sperm morphology and advanced chronological age, then you're more likely to have an abnormal embryo. If you have low sperm morphology and good ovarian reserve with chronological age within the normal, which will be under 35, then probably morphology doesn't have the same impact. There are some initial studies to suggest that the use of antioxidants may improve morphology. Quality of life, lifestyle could improve morphology. So morphology has a negative impact on fertility, I agree. And there are some laboratory-based techniques, one of these called IMSI, IMSI, which has been used, although the evidence again is not very robust, and is a way to select sperm with a high magnification compared to ICSI. IMSI use some lenses that have 400 times more magnification compared to standard ICSI. So in theory, the embryologist should be able to see the sperm better and choose the sperm based on morphology.
That's really interesting, because I think this patient's follow-up question is, so ICSI alone will not solve morphology problems with sperm? I think
No, will not solve the problem alone. No, I say I would recommend. Obviously, it's difficult to answer the question with limited information. Female chronological age, lifestyle, the male age, body mass index, smoking, alcohol intake, working environment. These are all factors that affect sperm morphology, which, if changed, could potentially per se improve sperm morphology. In addition, the use of antioxidants or vitamin C, vitamin D, coenzyme Q10, selenium, zinc, vitamin E could also improve the sperm morphology. And ultimately, there is some weak evidence, as I say, that IMSI, which is a high magnification ICSI, so it's done with the same equipment as an ICSI, but with a special lens, special lenses, could potentially improve the selection of the sperm, because we'll be able to look at the sperm with the high magnification, which ICSI per se doesn't do.
Okay, thank you. Another one here, we'll get a patient who's 49 and they're perimenopausal, and they have no family and they're desperate to use their own eggs. Do you think it's even worth this patient trying IVF using their own eggs at 49 and perimenopausal?
Personally, I wouldn't do it. I wouldn't treat a patient that, apart from age, has got hormone levels close to the menopause, because the chances of a successful outcome are very, very slim. I would say probably close to zero. And we need to bear in mind what is the potential impact that is emotional and financial after a failed cycle. So I would discourage this patient from attempting IVF with their own eggs.
Thank you. Okay, I'm going to move on to the Q&A and I'll just go through these questions. We've got a patient here that's had 3 early miscarriages before 10 weeks. They're able to get pregnant, but the body doesn't seem to want to hold on to them. What would help, if anything, and could progesterone help even if early bleeding doesn't occur? Can you take progesterone to help implantation?
Yes, implantation. Well, progesterone is given more than just to help implantation. Could help implantation because progesterone also has got an immune role. So progesterone per se could improve the immune system, and as such could improve implantation. But in this specific case, perhaps the use of progesterone could help to maintain the pregnancy. And we do recommend taking progesterone. Progesterone, as we know, is available in different preparations: oral, vaginal, and subcutaneous. There's also a intramuscular progesterone, which is very painful. So the available preparations are oral, vaginal, or rectal, intramuscular, and subcutaneous. The best form of absorption will be the vaginal and the subcutaneous. In a woman with a history of recurrent pregnancy losses, if unexplained, I would advise to take subcutaneous progesterone twice a day, and that is my recommendation.
Thank you. And similarly, I've got another person's asked the question, what test would you recommend for recurrent miscarriage? This patient's had blood panel done, thyroid, they've had endometriosis, adenomyosis, and they have mild polycyclic ovary syndrome, but their consultant doesn't seem to think that's affecting their fertility. They've had 3 early losses within the past year, and looking into natural killer cell testing and DNA fragmentation. Every time they've got pregnant, they felt really unwell, so they're starting to think, is there an immune system going on, and they're feeling really lost, and no one's helping them right now.
It's similar to one of the earlier questions, Sharon. It is frustrating. I say it is a dilemma. I would certainly not give much value to NK cells or any expensive and not evidence-based immune testing. And that's not what we do anyway. Also, with regard to sperm DNA fragmentation, the evidence is not out there to say that an abnormal sperm DNA fragmentation test can definitely cause miscarriage, may cause miscarriage, but generally can be overcome by the use of ICSI, and sperm DNA fragmentation test improves with the use of antioxidants. When there is DNA damage in the sperm, that is not forever. That may be a temporary damage, and say with lifestyle changes, antioxidants could improve. But in terms of the test to do, certainly checking for thrombophilia, karyotype, thyroid, a diagnostic hysteroscopy, excluding the presence of endometritis by doing an endometrial biopsy, or a specific test that will show if there is endometritis. And as I said before, there is some evidence that pre-implantation genetic testing of the embryos may improve the chance of having a live birth, because it would exclude embryos that are genetically aneuploid, so genetically abnormal, that could lead to an early pregnancy loss. And that, just for the benefit of our audience tonight, Sharon, about 90% of the miscarriages are down to genetic causes. So excluding that the embryo is genetically abnormal should per se enhance the chances of a live birth.
Okay, thank you. That's really interesting. And that same patient's also asked the question, their thyroid levels, and I think you touched on this earlier, have been 5 in the past. Currently they're at 1.3, but their thyroid function is never discussed when they're having follow-ups in relation to their miscarriage. Why isn't that tested as a routine when they know that this patient's suffering from varying thyroid levels?
I think the ideal thyroid levels, when we say thyroid, we talk about the TSH levels, the thyroid stimulating hormone levels, should be less than 2.5. There is some evidence to suggest that levels higher than that could lead to implantation failure, early complications, and pregnancy-related complications. So that's the reason why the use of levothyroxine per se could be very, very helpful in reducing the TSH levels to 2.5 or below.
Okay, thank you. Okay, I've got 2 questions that are talking about AMH. What is the recommended protocol for a patient with low AMH? Would you put them on a long or a short protocol for their IVF?
Yeah, I'll let perhaps Anna to talk about this, because she knows our protocols, but the majority of our patients will be using a short protocol, but I'll let Anna to talk about the protocols and individualized care when it comes to controlled ovarian stimulation.
Yes, so most of the time in our clinic, we are using short antagonist protocols for most of the patients, obviously with low AMH or with the normal AMH. So we are trying to put them on around 300 or international units of medications, could be Gonaleft or combination of Gonaleft and Menopur. So it's 300 of Gonaleft or 150 Menopur. So yeah, so most of the time we are very rarely using long protocols.
All right, thank you. Another patient here, if I just link that one in, they've got very low AMH, 0.3, and high FSH, between 20 and 29, I think they're saying here. They're 35 years old. Is it worth that patient trying IVF using their own eggs? And what do you think their success rates, if that's the only factors we were measuring?
Unfortunately, I don't think would be worthwhile trying. With FSH levels over 20 and with AMH levels so low, clearly this is an instance of ovarian insufficiency or premature ovarian failure. So no stimulation protocol will be able to stimulate follicular recruitment. And I have never seen in 25 years practice anyone with levels higher than 25 reaching a collection.
Okay. Okay, I know that might be a really tough answer to hear, and remember the charity is here to support you. Please feel free to contact myself, reach out to us through social media, or give me a call. My number's on the website, because there is other options in terms of, you know, donor eggs. But reach out to us to have a conversation about that one. Another patient here is asking if they have low levels of urea plasma, can that have an impact on IVF outcomes?
It could have chronic low urea plasma levels could impact implantation, and I think adequate antibiotic therapy should be prescribed. So that would be my recommendation.
Okay, thank you. We've got another patient here. How important is PGTA testing of embryos for the first round of an IVF cycle? The female's 37, the male's 39, and it's male factor, low motility and morphology, and DNA fragmentation of 28%. Would you suggest that patient goes straight for PGT on first round, or would you give them a cycle to see how it went? Sorry,
Sharon, can you repeat the first part of the question, please?
The patient's asking, this is their first round of IVF coming up, and it's male factor, female's age 37, male's 39 years old, and the DNA fragmentation is 28% in the sperm. Should that patient go straight for PGTA testing?
Yeah, as I would say, the value and the clinical value of sperm DNA fragmentation testing is not part of a routine clinical care. But the levels that have been quoted are more or less normal. I think anything less than 30 would be considered to be normal. I mentioned already that pre-implantation genetic testing should not be seen as a way to increase live birth rate. Could be seen as a way to reduce the risk of miscarriage in couples who have a history of recurrent miscarriage. Remember that pre-implantation genetic testing is expensive, and pre-implantation genetic testing will help to select euploid embryos. If you've never tried IVF, if you have a normal ovarian reserve, I don't think you need to embark on PGTA in your first cycle of IVF.
Okay, thank you. Next question, what are the treatment options for thin endometrium and adenomyosis with a luteal phase defect?
This is interesting. It's particularly interesting to me because I have a clinical interest in endometrial problems and adenomyosis and implantation failure. And I was very privileged recently to treat a patient who had several failed IVF cycles with a history of adenomyosis. She failed with her own eggs and with donor eggs. And she had multiple adenomyotic nodules visible on ultrasound scan. And my recommendation was to down-regulate her with 3, 4, 5 months of GnRH analog to enable the endometriosis to shrink, as the adenomyosis to shrink, and improve endometrial performance. And I did a viability ultrasound scan for last week, and she was delighted to have a singleton intrauterine pregnancy. And I think, in my opinion, medical treatment for adenomyosis is preferred to surgical treatment. Surgical treatment is invasive. Surgical treatment will reduce the normal endometrium within the uterus, may also increase the risk of adhesions within the endometrial cavity. So medical treatment with GnRH analog is the preferred option. And this should be at least 3 months in most cases of adenomyosis, but could be longer if the patient's got extensive adenomyosis.
Thank you. Anna, one for you. Would you recommend patients cut out sugar and fizzy drinks and a diet high in sugar prior to IVF, during IVF?
So we are always recommending to have a healthy diet, and obviously the advice will be not to cut everything. Obviously they have to enjoy this time as well. So definitely recommendation is to have a healthy diet, but if they feel they obviously need to eat something sweet, is definitely fine, and obviously doesn't change the outcome of the treatment or chances for the successful pregnancy. And as I said before, we have the useful informations on our website regarding of the diet and the preparation for the pregnancy, obviously during the waiting time or later on during the pregnancy. So I will advise to check our website for more informations.
Okay, thank you. Another patient's asked here, what's the kind of questions you should ask a clinic to help you choose a clinic? They're saying, does it matter what incubator or embryoscope they're using that their embryos would go into? But do you have the top 3 questions you would ask if you were a patient of a clinic or a clinician?
Perhaps I leave Anna to answer first, and then I will just comment afterward.
I mean, if I will be a patient, I'll probably first check the success rate of the clinic before I will ask these questions. And obviously, I think there is firstly, the important will be the consultation with the doctor to check the results, like AMH, and obviously to have a semen assessment before they will be able to advise about extra things like obviously embryoscopes. As we know, these are add-ons, so there is no strong evidence. So obviously, if the patient never had a treatment, I think they need to start with the normal IVF cycle based on the results.
Okay, thank you.
I think in addition to what Anna said, when any patient is looking for a clinic or the perfect clinic, the things to ask are, what treatment do I need? And does the clinic have the expertise for what I need? That's the first one. Second, how is the clinic going to support me throughout the treatment cycle? Third, will the treatment I receive be standard treatment or will be tailored to me? Because no patients are the same. And all the centers, as I presented in my very short introduction, offer IVF, but not all the centers have the same expertise. Not all the centers have the expertise for surgical sperm retrieval, for instance. Not all the centers have the expertise for treating a kind of patient or kind of condition associated with infertility. So I think the expertise of the center, the personalized care, the team, the protocol, these are all important questions to ask. And as Anna said, ensuring that the clinic has got success rate that is acceptable and is on at least on similar to what would be expected to be in other centers across the country. That is also very important. It's not based on the availability of some technologies only. And certainly I would not be choosing a clinic because they have an embryoscope. And again, in my experience, having practiced for many, many years and having visited many IVF clinics across the world, most laboratories are very well equipped. Yeah. And I don't think I could choose a clinic based just on having a laboratory with an embryoscope or not. So I think there are more important questions to ask.
Thank you. I'm going to start speeding these questions up now, or we'll never get through them all. Anna, why is the BMI of under 30 recommended in the UK?
I mean, most of the clinic will recommend this because of the sedation during the egg collection. So obviously they would like to make sure the patient is safe. But again, depends of the patient, how the patient looks like, because not every patient looks the same. So obviously if they are a bit bigger on the top part, then obviously it will be a little bit worse for the procedure. So everything depends, but obviously most of the clinic will recommend this. Worldwide, some of the clinic are recommending a bit higher BMI. So obviously it is possible to still have a treatment outside of UK with the higher BMI, as obviously the clinic, they have a different regulations. So some of the clinic in UK, they also accept below 35. So I think it's very individual based on the clinic policy.
Okay, and next question is, I'll ask this as a double question. Does coenzyme Q10 help with any specific conditions? Does it help with endometriosis is what they've asked?
I think coenzyme Q10, also known as ubiquinol, is an antioxidant. Can help with endometriosis, can help with anything that causes oxidative stress to our body. Can help men and can help women. Can help doctors overworking, nurses overworking, and the stress of living every day. So it's not specific for endometriosis. And I always recommend to my patients embarking on fertility treatment to take coenzyme Q10, such as other vitamins, just to increase the chances to give the body the best, for the body to be the best environment for a pregnancy.
Okay, thank you. Another patient's asked, when is it safe to have sex after embryo transfer?
I leave Anna to mention, because that also is in our guidance post-embryo transfer.
I mean, what we are recommending initially, not straight away after the transfer, because obviously there is the transfer is the procedure and there is always a risk of infection. But of course, a couple of days later, a few days later, it's definitely safe to have this. So it's perfectly fine.
Okay, thank you. I'll come back to you, Luciano. Patients suffering from severe, probably not pronounced this right, oligozoospermia and asthenozoospermia. Currently 1 to 2 sperms seen in 20 times magnification. As days passes, will the sperm count decrease? Currently it's less than 1 million.
Okay, so yes, this is a severe oligozoospermia, and asthenospermia refers to very, very few sperm and also with bad morphology. In these cases, I would recommend something called multiple ejaculation and cryopreservation. So I would recommend this gentleman to attend a clinic where actually he can produce several samples over a period of 3-4 days, and the sperm can be banked and then used when the time comes. This is very important because it may be that the sperm in one single ejaculated sample not be enough and not be of perfect quality. We have, for instance, for this specific case, we have expertise in one of our centers where we know they specialize in male factor infertility, and the use of multiple ejaculation and cryopreservation is standard But most clinics, on the advice of our fertility physician, should be able to provide that service.
Okay, thank you. Another patient's asked, what test, if any, would you recommend for someone that had non-implantation with 2 grade embryos? They weren't PGTA tested. Would you do any further testing, or would you just put that down to an unsuccessful round?
It could just be, absolutely, it could just be an unsuccessful round of IVF. I would say that implantation failure, as a definition, kicks in after having had at least 3 good quality blastocysts has been transferred. They don't have to be genetically tested.
Okay, thank you. Is it typical to have the number of eggs collected in each cycle decrease?
So the number what, sorry?
So if a patient goes for multi-cycles, would you expect to see the number of eggs collected
Eggs.
decrease?
No, normally I would expect the number of eggs increase or be the same. Again, depends very much on the ovarian reserve, the number and the size of the follicles. They trigger the stimulation protocol. But normally in a multi-cycle protocol, you would see the number of eggs in the 2nd cycle, and in the 3rd cycle to be the same or even higher.
Okay. A patient has low progesterone. I've tried progesterone twice daily, clex and injections and aspirin for the 3rd loss. They've had repeat blood tests and found out they've not got APS syndrome. All tests have come back fine. I think we've covered this earlier. What they're saying is they've had 3 losses very close together and have had 2 miscarriages. Is there any possible reason? And I think you've already covered this, that you know, you've covered the other testing that you would consider. Somebody else is asking if they had a failed IVF, could it be due to a progesterone issue?
Could be due to progesterone.
Yeah, could they have?
Yes. Yeah, low progesterone levels could be responsible for an abnormal endometrial performance, which could lead to implantation failure. Absolutely.
Okay. We've only got a few questions left. Oh, here's quite an easy one. I'm sure the answer will be not quite as easy. How quickly can a patient's AMH levels drop? So I take it they're meaning by age. So if they're tested today, will they still be the same in 6 months' time?
Yeah, the answer is I don't know. In some cases, ovarian reserve is steady for a certain period of time. In some cases, we've seen ovarian reserve changing within a month. So everyone is different. Ovarian reserve can change, can decline at any time, and there is no notification you will get by message or by email to say it's going to change next month. So you cannot just rely on a good sample, good level today, and wait 6 months or 12 months.
Okay, thank you. I've got a patient here that's currently on day 11 of their down regulation for the 2nd IVF cycle. With 7 eggs collected and 5 normally fertilized, but transfer failed using our own one. It was a low-grade embryo. Others didn't make it to 5 days. They both had COVID and they've heard mixed reports. Can COVID affect the quality of eggs and sperm?
Yeah, at one point we thought COVID could affect anything, but evidence and studies have come out showing that COVID per se is unlikely to affect gametes, eggs, and sperm. So I would not put it down to COVID. Okay,
thank you. A patient's recently had a hysteroscopy and a laparoscopy to remove endometriosis. However, their ovaries and tubes were healthy. They've been trying for several years and never managed to conceive. Is there any recommendations you would make for that patient?
I think the hysteroscopy is normal, the laparoscopy is normal, the tubes are patent, but there might be other underlying fertility causes of infertility. Yeah, so for male or female infertility. So I think it's important to undergo a full set of tests. And it's good that the hysteroscopy is normal, it's good that tubes are patent, it's good that the laparoscopy is normal, but might be other reasons. And I think the full investigation should be carried out.
Another couple of patients have asked the same question. Can a patient improve their egg quality?
There's no evidence that you can improve egg quality. Okay, and there's no recommendation, medication that can be given to improve egg quality.
Okay, thank you.
That is a straight answer.
Okay, what treatment would you suggest for a couple who are 30 years old and have unexplained infertility?
Anna, do you want to comment on that?
I mean, if there is unexplained fertility and we know how long they are trying, and we know obviously if the results are normal, probably we will recommend the standard IVF cycle because they are young, so there is no need to do like any genetic test at this stage. So probably that will be recommendation, if you agree.
I agree fully. There's no benefit of doing ovulation induction. There's no benefit of doing intrauterine insemination. If it's unexplained infertility, you've been trying for more than 12 months and the tests are all come back as negative, IVF will be the best option. One, to assess the eggs, the quality of eggs. Two, to see whether eggs get fertilized and blastocysts formed. And three, if you do get to that stage of blastocysts, then you will be shortening the time to pregnancy by having an embryo transfer.
Okay. Another quick one, is a frozen transfer better than a fresh transfer?
I wouldn't say that a frozen transfer is better than a fresh transfer. I would say that a frozen transfer is as good as a fresh transfer. And there are cases when a frozen cycle is better because in the fresh cycle, there might be underlying problems.
Okay, I've got another patient here that's obviously having real trouble with their clinic in relation to stopping the progesterone, and the patient doesn't feel comfortable that they've stopped progesterone. Is there a way that that patient can get the progesterone tested outside of their clinic and their GP?
Anna, you can answer that question, perhaps.
I mean, I'm not sure, is this the progesterone, when she had this progesterone? Is it during the treatment or during the waiting for the pregnancy test, or before, during the transfer?
I think it's during, they said their day 21 level is only 24. Does that mean anything to you guys?
So I assume if she's got low progesterone levels and she would like to take some progesterone, yes, she could take the progesterone. And if she's got low progesterone levels and she wants to be tested for progesterone and the clinic is not testing her, of course, she can attend any laboratory and request a progesterone test.
Yeah, so maybe 7 days after the ovulation, if she knows when she had ovulation, she can have a progesterone to check if it's in the normal range.
Okay, thank you. There's a few more questions and I'm really sorry, everyone, we've already run right over time here. So I'm going to have to stop it there. My email address is on the webinar that you joined from social media. So if you've got an unanswered question, drop it over to me and I will forward it on to Luciano and Anna to answer after the event. I hope you found today useful listening to other people's questions and actually getting you know, a clinician and a senior nurse to actually answer those questions. I found it useful. I've learned some things today that I didn't know. This event has been recorded and it will be put on our website in the next few days. And thanks, somebody's already said thanks, it has been really helpful to them. So that's really useful for you to know that. As you know, Fertility Network is a charity. You know, we don't favour one clinic or one organisation over the others. So I'm not saying that you need to go to NOW-fertility. They're just one of the many clinics out there, although theirs is a bit different. And, you know, I'm really thankful for Luciano and Anna for offering and agreeing to do this for the charity, because I think it's really, really helpful for patients to actually be able to access a clinician in real time. So thanks very much, Luciano and Anna, for giving up your time for our patients. Thanks very much. And without further ado, I'll just end the webinar. So thanks, everyone.
Thank you, Sharon. Thank you very much. Thank you.